I think the scientific challenges in psychiatry that interest me anyway will be harnessing the genetic advances. I mean, this summer we saw the publication of a mega-analysis of all the GWAS studies that have been done in schizophrenia, giving many, many thousands of patients, many, many thousands of controls across borders, you know, different places involved. And the study allows one tremendous statistical confidence that the thing we call schizophrenia, whatever that is associated with about 100 genes at least that show variation in the normal population, but when acting together are probably underlie and explain why people get schizophrenia. Now that's a landmark discovery. It means you can't really just describe schizophrenia as social labeling unless you think social labeling is defined by genes, which would be an interesting way of defining social labeling. But it seems to me that it's the absolutely crunch finding that we have not really had previously, because the power of the study, when you get to 20,000 patients, 30,000 patients, north of that, and this has happened in other branches of medicine to get complete statistical confidence, you've got to go to very large numbers. And once you get to very large numbers, you get very confident about what you found. And that is where we now are with schizophrenia. It's where we will be with bipolar disorder. It's probably where we will be with other of the psychiatric disorders. And it means that we will, within certainly the next few years, have a genetic map of psychiatry which is unlike anything we've ever had before. The second kind of thing that I think we are on the verge on is probably getting a serious handle on non-drug treatments in psychiatry. I think particularly the psychotherapists have in a sense relied on a folk model of treatment which has been very relaxed about the comparison, very relaxed about the placebo condition. And that means, and we know this from drug studies, that means you can delude yourself about what works and what doesn't work. And it may be that what works is very non-specific, and you get a completely pseudo-specific interpretation because that's what the therapist chose to do. They chose to use a CBT model, they chose to use an interpersonal relationship model, they used a behavioral model. And if you don't have an adequate comparison, all of the effect you describe may be non-specific. It seems to me that the real challenge is to bring contemporary neuroscience to bear on this, so that these models are instantiated, for example, in imaging or in chemistry or in whatever you can measure in the brain. And of course, that's our ultimate limitation, is that we can't measure things as directly in the brain as we'd like to. But bringing those kind of measures to bear on psychological treatments, behavioral treatments, I think is a next sort of frontier which I would really, really like to see breached, because I think people have shied off doing that for too long. So I think there's no doubt in my mind that it's the great privilege of coming to Oxford and Cambridge is you get the time of people who know a lot more than you about the world and about the specialist subject that you're reading, and who have got the time and the inclination to impart their experience and give you inspiration. So that's what it's about.